So I've been given the task of giving you a little bit of concept of what's the difference and how it works for a fixed versus mobile bearing unicondylar knee arthroplasty. Um, so just to give you a little background of the design of the unicondylar knee arthroplasty, Campbell in 1940 was the first man who came up with the concept of partial knee replacement. And what he did was just an interposition of battalion plates in the medial compartment, followed by McKeever, who designed a slightly different, same kind of plate just to replace the tibial side of the medial compartment. Gunston in 1970 was the man who first came up with this idea of replacing both tibial and femoral side. And all of these reported a revision rate of 10% in the first 2 years, which wasn't very pleasant. Then we had this St. George sled and marmor prosthesis in 1970 and 1980s. And again, they had a slightly better survival, 70 to 80% for 4 to 6 years. And finally, we had this Oxford UNI Goodfellow and O'Connor in 1986. So just to give you a little concept, McKeever had this tibial side, then McIntosh, then Gunston, and then we had a modern design introduced by St. George sled. And the figure on the right hand side shows us the modern unicondylar knee arthroplasty, mobile bearing versus fixed bearing. And all of this was because there were design issues, there were poly issues, as we are very well aware, in the hip, and there were indication issues, and eventually the target was to have a better survival and patient outcome. So we will be talking about this. So I just thought when I was preparing my talk that I should just make it clear and precise, especially because we don't do unis in Pakistan. So I thought we should discuss clearly about the fundamental concept in design, why mobile bearing and why fixed bearing, how does it affect your surgical technique, and does it really matters in terms of outcomes pertinent to these two designs. So start off with mobile bearing. This design is basically allowing more congruent joint, therefore it ends up having a natural knee kinematics with higher degree of conformity between the articular surfaces. And why conformity? We all know from the basic science that it is supposed to reduce the surface and subsurface contact stress with less likelihood of poly wear. And if you have less likelihood of poly wear, then you have less likelihood of loosening or early loosening. So fixed bearing designs would have more wear as compared to the congruent mobile bearing design. But for congruent surface and a conforming range of motion throughout the flexion extension arc of knee motion, you don't only need a conforming surface, you also need an intact and healthy ACL, and you need a good functional MCL without being overstressed, because if you have mobile bearing, then the stress on the MCL changes from full extension to deep flexion, and that brings you to the inherent risk of bearing dislocation, which is a part of the package in mobile bearing knees. So when you talk about mobile bearing, then you have the pressure of getting it all together in the right place. So you have to keep the medial joint space a little tighter so that the bearing is just fixed in nicely and it just flips through the range of motion. And to do that, you end up having a slight overcorrection of the valgus, overcorrection into valgus, or overpressurizing the lateral compartment, which then kind of defeats the basic idea of long survival, because all we know is that once you do the medial uni knee, then you can end up having progressive arthritis in the lateral compartment, and then you can have early revision. So, when I was thinking about it, I thought it's just like when you are doing initial fellowships in your hips, and every one of us has been through it, and some of us might be going through it. Then when you start doing hips, you tend to have a tight hip because you don't want your initial hips to get dislocated. And when you tighten your hip, your abductors are a little overstressed, and you have limb length discrepancy and all of that. So it's just the same kind of mentality when you're putting a mobile bearing knee into the medial compartment. You want a tighter medial side so that the bearing is, smooth through the range of motion. It doesn't flip back or rotate. So, and that's why you are slightly less tolerant to component malposition as well as flexion extension imbalance in a mobile bearing knee. So when you're doing, surgical technique wise, when you're doing a mobile bearing knee, you are kind of overstressed with all of it. Valgus overcorrection, slight component malposition, flexion extension imbalance, overstressing your MCL or ACL, and under or oversized bearing because of all this going through your head. So you are kind of asking for a smart tackle. You have got too many people to tackle when you're making your move to the final component position and all of it. As compared to that, you have got fixed bearing. So it's less confirming. So a little micro motion between the tibial base plate and the polyethylene. And this geometrical design increases the likelihood of point loading. But once the bearing is fixed, as it flips into place, as you do poly in the hip or you do poly in the tibia, for TKR, it just fixes itself. So there is no risk of dislocation. But you have got a flat articular surface and you increase the likelihood of point contact through the arc of motion in weight bearing axis, and then you are more likely to have polyethylene wear. But surgically, when you do all of it, what you know is that you are allowed to have a slight loose medial compartment, and that makes your life easy. You can trial it, and if you are happy, you are happy. You are not overstressing the lateral compartment, and you are eliminating that factor of lateral compartment overload, and therefore reducing the chance of revision. So, in terms of surgical technique, I would say higher technical requirements and long learning curve is needed for the surgeon in mobile bearing design, which is not required in the fixed bearing design, and therefore it makes it more tolerant to surgeon related errors and more friendly for less experienced surgeons. Here comes, after all of this, the key question, whether it makes any difference. So if you are getting through that stress for a mobile bearing design or you are doing it the other way around, does it make any difference in outcomes? And it will include, of course, all of these parameters: knee score, range of motion, quality of life, radiographic outcome, incidence of reoperation, timings of failure, and survivorship. So here is the evidence. 2019 meta-analysis, 15 comparative studies, and the conclusion is there is no difference in the two operations in terms of revision rates, complications, knee function, but earlier failure can occur in mobile bearing design because of that flipping poly. Then next year, 2020, meta-analysis, 17 studies, 2,612 knees, no significant difference in clinical and radiological outcomes, but there was difference in modes and timings of failures. Bearing dislocation led to early failures in the mobile bearing prosthesis, while the fixed bearing prosthesis failed later due to poly wear. So it's kind of a flip coin whenever you want to. So then 2021, Dutch register, again the same problem. Australian arthroplasty register actually said that fixed bearing is better than mobile bearing, probably of the same key factor, bearing dislocation and problems. 2022 meta-analysis, 25 articles, 4,696 patients, no difference in range of motion, knee scoring system, function subscale, and Oxford knee score. No difference found in rate of revision, aseptic loosening, deep infection, fractures, and further extension of osteoarthritis to the contralateral joint compartment. Conclusion, they are similar. So I just thought then, fundamental concept of mobile bearing is more attractive because you feel for it, congruent throughout the arc of motion, more kinematic and all of it, therefore more attractive, but the surgical technique is a little more challenging. And outcomes, probably not superior, at least, significantly superior, either of them. So I was talking to Apton yesterday and I said, look, we are kind of having this operation as a newly born baby in Pakistan. Quite a handful of people I know that they do. Umar does it, I do it, Faisal do it, and maybe other people are doing, but not many people. And we actually are having is, challenges of implant numbers and implant coming over and all of it, but you guys are doing it more fluent. So I want you to reflect on it and guide me in terms of what is better. And he showed me this paper, and it actually shows the same thing. If you look at the bearing dislocation and polywear, so the bearing dislocation shows 11 numbers in the mobile bearing design with no bearing dislocation in the fixed design, which you don't expect anyway. But you have more poly-wear revisions in the fixed bearing design. So it's the same thing as we discussed, that the fixed bearing design is more likely to have poly-wear, and you would have a late failure, and you are likely to have more late failures in the fixed bearing design as compared to the mobile bearing design, but you would have less failure in terms of polywear in the mobile bearing design, but you run the risk of having bearing problems in the initial stages of mobile bearing designs. So, to conclude, what I thought is high volume and experienced UK surgeons can use mobile bearing design, and it's just like when you get bored, when you're doing the same thing again and again and you are itching yourself, let's do something different and glamorous. So maybe people who are doing it more and more, they can try this a little more glamorous design because they are more confident, they are more fluent, they are doing it more. So they can sort of shift their practice or balance their practice between the two different design concepts. But for somebody who is a beginner, who is handling the instrument with a little bit of a challenge, he should probably start off with a fixed bearing design. And as discussed with Epton, I guess if you look at the two design, it's probably not about mobile or fixed bearing. It's the decision of whether you want to do a unicondylar knee arthroplasty or a total knee arthroplasty. So I again, appreciate our shortcomings in terms of experience, and I would love to hear from these knee surgeons who have come around to Pakistan to enlighten us about this